Welcome to Developing Resiliency During the COVID-19 Pandemic, a program being presented on behalf of the Ismaili Jamatkhana and Center. My name is Humaira Qasim, and I am the Communications Coordinator for the Aga Khan Council for the Central United States. The Ismaili Jamatkhana hosts events that inspire to stimulate the intellect, encourage dialogue, and celebrate cultural diversity. We host these events under the guidance of His Highness the Aga Khan, who is the 49th hereditary Imam or spiritual leader of the Ismaili Muslims and a direct descendant of the Prophet Muhammad, peace be upon him. The ethos of today's program and other such initiatives is perhaps best captured by His Highness the Aga Khan when he delivered Stephen A. Ogden Memorial Lecture at Brown University in 2014. I quote, "Progress is possible when multiple diversified needs of any society can be matched by multiple diversified inputs. That is also what civil society is all about. Progress is possible when complex issues are subjected to competent, intelligent, nuanced, and sophisticated analysis, free from dogmatism and based upon what I would describe as empathetic knowledge," unquote. It is my pleasure to introduce today our first panelist, Dr. Philip Wong, Director of Dallas County Health and Human Services. If you live in North Texas like I do, he's a familiar face on our TV and our computer screens as he has helped guide the North Texas community through this COVID-19 pandemic. I remember being glued to the TV back in March when this pandemic was becoming very real and very tangible to most of us. His calm demeanor and ability to explain complex issues make him the voice of reason in the Dallas community. Our second panelist today is Dr. Fred Cerise, President and CEO of Parkland Health and Hospital System. I have had the pleasure of listening to Dr. Cerise speak on the pandemic previously. Dr. Cerise brings a tangible perspective about the pandemic. However, it is his passion for his employees at Parkland that truly made him remarkable. Both of our panelists have demonstrated resilience during this pandemic, and we're looking forward to hearing how the audience today can do the same. Our moderator today is Dr. Salim Virani. Dr. Virani is a professor of sections of cardiology and cardiovascular research at Baylor University. Dr. Virani also serves as the chairman of the Aga Khan Health Board for the United States of America. And with that, it is with pleasure that I turn the panel over to Dr. Virani.
Thank you, Humaira, for the kind introduction. So without taking any further time, what I'll do is, since we're talking about resilience in the face of this pandemic, maybe I'll ask each of our moderators to say a few things as to what has kept them going through this very tough pandemic. Dr. Huang, you serve as a county official, and Dr. Cerise, you work for a very large hospital system, perhaps the largest county hospital in Dallas. So what has kept you going through this very long and very tough pandemic? Well, maybe we'll start with Dr. Huang first. Dr. Huang, you want to go first?
Sure. It has been a long haul. I think for us in public health, this is probably what we all prepare for throughout our careers. What's kept us going is certainly the needs of the community. We have a lot of dedicated staff. The commissioners, Judge Jenkins, have been very supportive of our efforts. So it's that support, and I think just the support of all of our staff at the Health and Human Services Department, recognizing that this is what we need to do to serve our community.
Perfect, thank you. And Dr. Cerise?
Sure, and I would agree with Phil. This is what everybody trained to do if you're in healthcare, and so it's inspiring to see how our staff has responded from the early days when there was a lot of uncertainty to now when we've kind of figured out some of the things around safety and how to approach this the disease itself. But really, the thing that keeps you going is there's great need in the community. We get a lot of community support. We have felt that, and it's a matter of the team stepping up and doing what they were trained to do.
Perfect. Thank you. So with that, let's start out first discussing a little bit about where we are with this pandemic in Dallas area, as well as the state of Texas and US. Dr. Huang, you want to just fill us in on where we are and where do you think this pandemic is going now?
Sure. As Fred mentioned, it's been it's been evolving and everything's been new. You think back to where we started back in March, and then we did our first shelter in place orders, and we successfully slowed things down. We had some plateauing, and then came to Memorial Day, and things really, people were getting tired of it. The states opening things up. People started thinking we could just go back to normal, and we saw really explosive growth in the number of cases, hospitalizations, all of that. We hit right before July 4th and said we couldn't have a weekend over July 4th weekend like we had over Memorial Day. That was the week also. Then there was the order for universal masking, closing of some of the bars. So we were able to slow things down after that big spike. We hit some peaks in mid-July, and then saw declines in all of the numbers of new cases, hospitalizations, all of that. But then now, starting to, we got to Labor Day, started seeing, again, some relaxation of things. And so since probably mid-September, have been seeing increases in a lot of these same indicators. And so we're very concerned about where we're going. We've been working again with Dr. Cerise and his staff and the other hospital systems. Some of them have said if we kept on the same trajectory for the next couple of weeks, we could be seeing the same levels we saw at the peak during the summer. And, but it's all dependent on how we as a community, respond, because we've shown that when we do the right thing, we can slow things down. But then we're also getting into flu season. We're getting into the winter months when people are inside more, and we're getting to the holidays. So a lot of various factors that can influence this.
Nice. So going back to what you mentioned just now, Dr. Huang, we know from the 1918 pandemic, the pandemics in 50s and 60s, in general, the second waves have taken more lives compared to the first wave. Does that pattern worry you, or do you think that we will be okay? Because it looks like we probably are in the middle of a second wave in US with more than 100,000 cases now for the last 1 week and still going up. Hospitalizations also slowly picking back up, and the predictions are that deaths will soon follow. So how much does that worry you as a public health official? Do you really think that this time around, again, we may suffer more damage as a community, as a nation, with the second wave of COVID-19 that we are going through right now?
Yeah, absolutely. very extremely concerned about it. I just saw the report today, over 10 million cases also in the US, and rates rising in 43 states. Again, talking to our hospitals, and I know Fred can elaborate, what Parkland's seeing, very concerning, certainly from our standpoint. And I'll let him add more.
Now I'll revert to Dr. Cerise, and I think Dr. Huang briefly mentioned that as well. Of course, one of the biggest worries is that is this going to overwhelm our healthcare systems? We briefly saw that in the months of July and early August in Texas as well as a state. Where do you think things are right now? And has that experience helped us? And when I say us, I mean not just Parkland, but other hospitals as well. Where do you think we are in terms of the supply of healthcare professionals, the ventilators, ICU beds, as well as PPE? Where do you think we are? Are we prepared to take care of this large swath of patients that we may see?
So I think in North Texas, we still have some capacity today. And if you just take Parkland, for example, we peaked at about 180 cases in mid-July. And then we came down, as Phil talked about, to where we had about 30 people in the hospital with COVID. We've gone back up now, and we're up above 120 or so. So we're headed back up, not as bad as it was in mid-July. But the worrisome thing, as Phil has said, is that, we're still on the upslope right now. So we know we have more capacity. If you just look at beds, and ICU beds. We're kind of in the mid 80% occupancy in those categories right now in North Texas. However, if you were to look down south, look in El Paso, they're overwhelmed right now. In fact, we are taking some transfers out of El Paso into the rest of the state, and including the Dallas region right now. So we have capacity today. I don't expect that the pinch point for us will be, some of the things we were concerned about before, PPE or ventilators, because we've got adequate supply of those things. If it gets if it gets really active, where will be challenges with staff, because everybody around the country is dealing with the same thing at the same time. And, there's not a workforce that you can naturally expand. Everyone's competing for the same healthcare workers right now.
Oh, that's a great point. So Dr. Hong, the other thing that we notice in Dallas is that even when you look at various counties, so you look at Collin County and you compare it to Dallas County or Tarrant County, the numbers, per 100K of the population are vastly different. What do you think is driving those differences even amongst counties that are very much surrounding counties? Is there something that can explain that?
Sure. I mean, there have definitely been some particular areas that are more vulnerable, whether due to, and Fred and I worked on the community health needs assessment before all this, and, pointed out some of these areas of Dallas County that have the highest burden of, even some of the chronic diseases that are put people at higher risk. Also the demographics and socioeconomic status, some of the, Hispanic, African-American populations have higher burden, being the essential workers are at higher risk, and, less able to do teleworking, and, more pressures to go into work when they need to. And then the home situations might have more multi-generational families in the households. So all those factors, play a part of it, in the urban areas of Dallas, more dense than perhaps some of the suburbs. And those, we are definitely seeing some differences with that.
I see. And are you seeing any trends, what we are seeing nationally in terms of family gatherings, small gatherings driving a lot of these numbers? Is that the same trend you're seeing in some of these large counties in Dallas?
We definitely are seeing that, again, the COVID fatigue, and it can be some of these family gatherings that account for it, but we know what, it's crowds. It's when people get together, when they're not wearing the masks and not physically distancing the 6 feet. So definitely it's a lot of different factors. I've seen some things also lately, some increases even in the long-term care facilities, some of the daycare settings and childcare settings, perhaps loosening of, not, again, being as vigilant in some of the infection control practices as previously. So just, but it's not any single factor that's accounting for it.
I see. And then, Dr. Suresh, in terms of the hospitalizations, the proportion that end up in the ICU, have you seen any change in that? And then again, are you seeing the same vulnerable segments of the population that Dr. Huang alluded to, who need a higher level of care even when they get admitted? Is that the same trend?
That's right. I mean, it seems like this time around there may be a little bit less of a percentage making their way to the ICU. Some of that may be practice changes. Some of that may be, we're adapting our practices a little bit more, but in general, anywhere from probably 2 to 5% of people that are infected will end up, in the hospital, and another 20% or so of those people are going to end up in the ICU, where there is a high mortality. And so we certainly are continuing to see, even though it's a small percentage overall, 1 to 2% mortality, as the overall case number grows, that number ends up becoming a pretty big number. And so, in Dallas County now, we're over 1,000 deaths from COVID now.
Mm-hmm. That's interesting. So in the midst of this, when we have so many cases, and I think this question goes to both of you, how do we even define success? Are there even good models from public health, authorities in terms of examples that we can use and say, this is what defines success for us as a county or as a state or as a city. I don't know, Dr. Huang, you want to go first, and then we'll ask Dr. Cerise the same question.
Sure, absolutely. The metrics that we've been monitoring, and a lot of them have been even the hospital metrics, whether it's visits to the emergency department, admissions to the hospital, ICU admissions, hospital census, and then ultimately, unfortunately, the deaths. As some of the key indicators, just because they're less dependent on what testing's going on, the delays in some of the testing reports and things that we're getting. But we certainly look at those numbers also. But we've seen how we can slow down the spread in the community when everyone does adhere to universal masking and 6-foot physical distancing and washing hands and avoiding crowds. So we've seen some success. Again, I think it was a morning news editorial said, we know what to do, we just need to do it. But it's not just simple to do. And again, everyone's getting very tired of it, but we have seen success, and certainly some of those metrics are how we can measure it.
I see. So what do you do as a county health official, Dr. Huang, when people are tired of wearing masks, keeping socially distanced, not meeting with their parents who are not part of the same household? How do you explain to them as the holiday season is appearing, what should they do that's practical?
I think we've evolved a little bit. We've had the red sort of transmission level and risk level and orange, and we went down to orange for a little bit. And Fred and I are in the public health committee sort of looking at all those metrics and helping decide that. But I think we also learned that, there is a pathway to do this more safely. It's not a total lockdown. If people will wear the masks, if they'll keep 6-foot physical distance and avoid the crowds, you can open some things up more safely if you adhere to those things strictly. And so that's a pathway that is not saying you can't do anything, but you just have to do these things and really be adherent to it. Then that's how, it's not total lockdown.
I see. No, that's a good point. So Dr. Cerise, from a hospital standpoint, as the CEO of a very major county hospital, how do you look at these metrics and say, look, we're making some progress? What would some metric be?
Well, the most fundamental one for us is hospitalizations, because you can debate a lot of the metrics. Cases may go up if you do more testing, and if you test mildly symptomatic people or asymptomatic people, you're going to find more people that never would have felt sick or ended up in the hospital. And so those numbers can vary by how aggressive you are with your testing, but the hospital numbers are going to be pretty consistent. Either you're sick enough to go to the hospital or you're not. And so that's the thing that we're able to look at it and track. And so we know we can gauge disease activity by how much that hospitalization is going up. So success for us, obviously, is fewer people coming to the emergency room, fewer people ending up in the hospital. There are some interim measures, like the positivity rate. We test at some sites out in the community, and we are seeing that the percent of people who are worried or feel sick who are showing up at those sites, that had come down to 13-14% or so, and that's back up to 18% now. And so that's a sort of perhaps an earlier indicator, but from where we sit, the most basic indicator for us is how many beds have people with COVID in it, and that's going to be a real measure of disease activity in the community.
I see. And I know, Dr. Cerise, it's still a little early for Texas in terms of the flu, but are you seeing any complicated flu cases already at Portland or no?
We're not, but it is, you point to something that we're all concerned about, and that is what would a bad flu season look like on top of people infected with COVID. And we know those cases exist. Those cases have been reported already. And so we're making a big push, and you all will help us with that too, to make sure the community is aware, because that's one of the things that we can prevent. We don't have a COVID vaccine yet, but we do have a flu vaccine. And so we want to make sure everyone is taking advantage of the flu shot.
So that really goes to my next question that I was going to ask Dr. Huang, that, what role do you think the civil society, faith-based organizations are, of course, part of that civil society. What role do they play as you see it as a public health official, and how can the two work together to mitigate the risk as much as possible in this case?
Well, I think, really being part of the messenger for the public health messages we're trying to get out there, being, demonstrating and implementing and actually living the, what we recommend with that. And we're very proud. Many, faith-based organizations, even though they were allowed to at the state level to open up, chose not to when the recommendation was to do so. And that's been a lot of what we've had to do, given some of the politics throughout this, is to say just because you can doesn't mean you should. And so again, Fred and I have been working on the Public Health Committee with some of this guidance documents, to what the experts, local experts in Dallas County recommend is safe to do, given whether we're in the red zone or the orange zone, or if we could get to yellow or green. And so definitely reinforcing those messages and actually implementing and showing how important it is very important, because many people get their guidance obviously from you all, and so the more we can show that consistent messaging, I think, is really important.
I see. No, those are important. I think all the faith-based organizations now take it as their responsibility, and some of them may be serving these very vulnerable segments that we were talking about. Dr. Reese, on the same lines, the other issue that I have personally felt as a physician, taking care of some of these patients, and then as part of a faith-based organization, is the communication when a patient is admitted to a hospital. It's not the same thing with COVID-19. A patient is admitted, the family really finds it very difficult because they can't be there. Are there any good practices in terms of how to then communicate with the families as well, who really are very concerned about a loved one who's at the hospital?
That is such a difficult one. You're hitting on such an important point, because we know when people are in the hospital, part of getting well, part of feeling better is having your loved ones around you, right? Having your family members with you. And that's been one of the hardest things for us during the pandemic, is that we've had to limit visitors to the degree that we've had to. Since we've learned more about COVID, we've been able to adapt our practices a bit, and have loosened up on some of our visitor policies, as long as people are adhering to masking and keeping a distance. And so we know, and I'm talking about now in the non-COVID areas, we know that under controlled circumstances, we think it's safe to allow a visitor, and as long as they're masked and the patient's masked, so that we're not bringing in anything or transmitting anything. We've had to rely a lot on this kind of communication that we're doing right now. And so putting setups in patients' rooms so that they can conference with their family and the doctors and nurses at the same time to try to improve upon that communication. But it has been one of the toughest things that we've had to deal with, to have to restrict that access at a time when people really need it the most.
Mm-hmm. So on the same lines, another related concept, Dr. Reese, that we have seen out in the community is the members in the community avoiding, coming to the hospital even when there is an emergency. Is there any message you have for people listening who might be concerned even when facing an acute MI or acute stroke? Because there are so many excess deaths that we cannot explain, and maybe some of that is due to deferral of care. Do you have any message for those people listening to you about safety of the hospitals?
Yes, and there have been some studies now looking at this, and the fact is there's very little transmission at the hospital from patient to patient, or staff to patient, or patient to staff. Again, early on, we were trying to sort this stuff out and trying to understand how the virus acts, but we've got a number of months of experience now, and people have studied it and written about it. And I go to work every day at the hospital, and I walk around the hospital, and I haven't been infected. People at the hospital have not been infected. When I leave my office, I take this with me. I put this on, and so we know transmission is low at the hospital. In fact, the employees that have turned up infected almost universally have acquired it in the community. Very few isolated cases where maybe they got it in the lunchroom, crowding around a table without their gear on, And so Transmission at the hospital is very low. So if you're having a problem, you need to be in the emergency room. The staff knows how to deal with this now. They will isolate appropriately. And so don't try to ride out chest pain or shortness of breath or other serious conditions at home. Hospitals are well versed in how to take care of this now, and you're not, the risk of acquiring COVID at the hospital is very low, very low.
Perfect. Thank you. Thank you for that message, because we see that in the community, there's a lot of deferral of not just care, but acute care as well.
Right.
We talked about, where we are in Dallas as a country as well. We looked at where the pandemic has been, a little bit about where the hospitals are. Looking to the future, so this question is for you, Dr. Huang, that, we had some good news today about a vaccine being more effective, at least in the preliminary side of things, compared to what we were expecting. So that's good news. We hope that this trend continues when the trial is finished for that particular vaccine and others. Where do you think we will be in 3 months from now as far as a vaccine is concerned? And what are the challenges that you see that we should be mindful of?
Sure. I mean, we're hearing, perhaps at the beginning of the year, there may be some availability of the vaccine. We've been having discussions, and I know, Fred and I have talked, and we've been having there's some other meetings. We've got some meetings later this week, working with the city of Dallas, and our public health committee has been looking at, some of the recommendations regarding prioritization when there is some limited vaccine initially out. But there are a lot of logistics that are going to have to be addressed. We don't know. I mean, depending on which particular product is out there, the freezer requirements or refrigeration to keep cold. If they require multiple, 2 doses, tracking that. The distribution, getting it out. Right now they're in the process of trying to sign up providers in the community to be able to provide that, but then need to have the capacity to report that to the state health department, and there's some requirements with that. So a lot of logistics to this actually being introduced and made available, and we're trying to work through some of those issues as we speak.
Nice. And any collaborations with any faith-based organizations that are in the works related to vaccine distribution once it becomes available, and the messaging piece as well? Is there anything that's happening currently that we should be aware of?
We've certainly worked a lot with faith-based organizations on distribution of the flu vaccine. Also, we've had some of our testing sites co-located, things like that. Right now, it is providers that are going to be sort of determining where that distribution point is. But we certainly want to get that, coordinate the messaging and that delivery. So welcome that collaboration and discussions and communication.
Yeah. So just to expand on that a little bit, because what we expect is early on, there will be limited supply of vaccine. And so there will be a prioritization schedule that is developed. The CDC has recommendations around this, and the states will have some responsibility to distribute out into the general population. And so what Phil referenced the work that we're doing, looking at that early on, what we're going to be, the providers, the healthcare providers, hospital systems, public health agencies will be looking at how do you hit those highest risk groups. Maybe it's the frontline healthcare workers, the people with pre-existing conditions, the people that are going to be most vulnerable, and prioritize that. And then I would fully expect later in the year, as there's more demand and you're trying to get that to the masses, where you can envision kind of the partnerships and the big drives and things like that we're used to seeing with the flu.
I see. And do you both see any issue with public perception of safety, which seems to be that perception is rising? We'll see what happens in the next few months, but that's been an issue as well. Do you foresee that? Is there any programming around that it is safe to take that vaccine once it comes out and has gone through the rigor of a clinical trial?
certainly, a lot of discussion about that, and we appreciated when the 9 pharmaceutical companies said they weren't going to rush this. They would, make sure that everything was done properly. We'll all be looking at the, processes and results and from the clinical trials, and I think all of us want to see, and make sure that the process occurs properly. And with that, those assurances and ability to confirm that, then I think all of us will feel much more comfortable with that. And we've talked about, we're happy to show our own willingness to, take the vaccine if it's properly, gone through the process.
So we talked about, preventive measures. Those, of course, will not go away even when we have a vaccine. Masks and physical distancing will remain important. We talked about the vaccine, some challenges, whether you need multiple doses, refrigeration. How do you get around the public perception of safety? The third aspect that Dr. Cerise, I wanted to ask you a little bit is in terms of therapeutics. So we have, steroids that has been a godsend in this particular case. We have remdesivir that decreases illness severity. Now we have some work around antibodies and all that stuff. Is there anything else that is in the works, or do you see any further work on the therapeutic side or the supply demand side? Do you see any challenges?
Sure, and that's been a mixed bag, as you indicated. Some of the traditional drugs that have been available for other things, like steroids, have shown some benefit for people who are more ill. But remdesivir has reduced time in the hospital from about 15 days to 11 days for people who require hospitalization. We've used convalescent plasma, but the results of that are mixed. And so unfortunately, there's not a therapeutic now that cures this, that makes it better. Dexamethasone for people who are severely ill, requiring oxygen, has a mild mortality benefit, but nothing where you take this and you're going to be well. The monoclonal antibodies, I understand that they're going to get emergency authorization imminently, is the message that we're getting. We're as a health system are preparing to be able to accept that drug when it becomes available. It won't be available in the quantities such that everybody who feels sick and is infected at an early stage would be able to get it where we think it's going to be most effective. And so we'll be setting up protocols to deal with that. That will require an infusion for about an hour for people. So they're going to have to be at a provider to get an infusion. And again, it's typically for people who are earlier in their disease state. So still a lot to learn about it. But I guess the bottom line is we're better at this than we were in February and March. But unfortunately, there's not a single agent that we can feel confident that is going to cure you if you come down with COVID.
I see. Now I'll switch gears a little bit because I know we have quite a few young audience as well, young people who are listening, and they will be making these career choices. Never in the past, I would say 30, 40 years, we recognize how important it is to be working in capacities that you both are in public health, as well as being the CEO of a large hospital that's really taking care of the needs of the community. So Dr. Huang, I wanted to ask you if you have any message for those young people who are listening to you, that you are an MD, but right now your focus is on public health. And then I'll come to Dr. Cerise, managing a large hospital system that's taking care of vulnerable population. So what is one message you have for young people who are listening to you and thinking about it as a career? What should they keep in mind?
I would say, and before COVID even, we had H1N1, we had Zika, we had Ebola. We've had a lot of pretty highly visible public health issues we've had to deal with. But this has certainly been the big one on topping all those. But hey, I would say if people are interested in public health, and I hear there's a whole lot more, now there's undergraduate degrees in public health. There were many for pre-med, many for other healthcare professions. And then, I have always said, I love public health. I love the combination of public health and medicine. As a career for me, it's been something that it's never dull. Again, a year ago, didn't imagine we'd be dealing with COVID-19. It's not like every day you go in and do the same thing. The breadth of what we deal with, whether it's immunizations, whether it's STIs, whether it's cancer, whether it's tobacco use. I mean, there's obesity. There are just so many different issues and so many skills. Whether it's epidemiology and data, or looking at the clinical system changes and treatment. Disseminating all these different new. Whether vaccines or working on treatment delivery. There's just so much you can do with it. So, I think it's a great career, and always happy to talk to people that are interested in it. I think it's a great career.
Perfect. Dr. Cerise, for you?
Well, I think anything you do, so I'm going to be concerned about risk, and a lot of our staff are concerned about risk, particularly with the unknown. So at the outset, did we have enough protective equipment to keep the staff safe? That's the thing that worries me the most when we're dealing with something like this. People go into healthcare to help people, and anything you do has a certain amount of risk associated with it, and healthcare is like that. And from time to time, whether it's Ebola or now COVID, that risk, the uncertainty may be a bit higher than in normal days, where you understand the disease you're dealing with every day, and you feel pretty confident that we have good practices to keep you safe while you're serving others. But listen, I've been inspired by the people here who have raised their hand to say, I want to go in and serve. During the times when we were still figuring out how to stay safe, how to protect the healthcare workers, we had people raising their hands and volunteering to go in there and serve. And so, when you look at the opportunity to make a difference, there can't be that many more occupations where you can go in and serve your fellow human and make a real impact. And we try to understand. We do the best we can to make sure we understand and are keeping people safe while they're doing it. You can't always guarantee that, and that's the thing that keeps me up at night is making sure that we're doing the best that we can to keep people safe along the way. And I can say, fortunately, we have not seen people in healthcare getting infected at a high degree. But again, if you want to do something to serve and to take care of people, when the public is at risk right now, and the public needs help, it's the time for the healthcare workers to stand up like you do, and it's hard to imagine an occupation where you can make such a difference, particularly at a time like this.
Definitely. So just wanted to ask each one of you, what is one public health message you have for our audience today? What is it that they should keep in mind? One message that you think is the most important. Maybe I'll start out with you, Dr. Huang.
Well, it'd be the combination: wear the mask and keep the physical distancing and avoid crowds. But those practices that people need to do.
Wear your mask, maintain physical distance. Dr. Cerise, one message you have for the community.
Yeah, that's the message. If I had to add something, because I see this from time to time, it's avoid the crowds. Don't go to the bar. Now's not the time to go to the bars. For the young guys out there, that time will come back at some point, but it's not right now.
Perfect. Well, with that, I really thank you both, Dr. Huang, Dr. Cerise. We know you both are extremely busy, but we appreciate you taking out the time, because this helps the community understand what the public health officials are thinking, where this pandemic is going. And I hope that a lot of these messages will lead to some changes in how we look at this pandemic at an individual level. What's our personal responsibility, and what do we do as parts of communities as well to take care of this deadly disease and reduce the impact as much as we can on our families as well as our community. So with that, I really thank you both for your time, and we look forward to connecting with both of you again sometime in the future. Thank you for your time.
Thank you.
Thank you. Appreciate it.